Welcome everyone, and thank you very much for joining us this afternoon. My name is Shai Adelson. I'm one of the founders of Fort Health. We're a mental health practice providing care for children and families in New York and New Jersey, while providing education sessions like this one for families all over the world. This webinar is part of an ongoing series of sessions that we're hosting in partnership with Child Mind Institute and a rotating cast of other partners. Each month, we bring together clinical leaders for a discussion about an important topic that affects the mental health and well-being of children and families. Our goal with these is to provide parents, educators, and primary care doctors with actionable advice based on clinical experience and evidence. This afternoon, we will be discussing Tourette's, a neurological disorder that affects up to 1 out of every 162 kids, and up to 2/3 of whom tend to be boys. For this topic, along with our friends from Child Mind, I am happy to welcome Dr. Eric Deibler, worked with Center of Emotional Health of Greater Philadelphia, and critically for this topic, with the New Jersey Center for Tourette Syndrome and Associated Disorders, which is the nation's first center of excellence for Tourette syndrome. And also welcoming Dr. Benson, who's the director of trichotillomania and tics at the Child Mind Institute. Now, according to the CDC, over 8 in 10 people with Tourette's also struggle with at least one additional mental health condition. From anxiety to OCD to ADHD to sleep challenges, Tourette's affects children's lives in more ways than just tics. So I'm also pleased to welcome Dr. Taylor Wilmore, who's a clinical director of InStride, which is a leading provider of treatment for severe anxiety and OCD, and Dr. Lindsay Henderson, our clinical director at Fort Health, an expert on behavioral disorders and ODD. Thank you, all of you, for joining. I'm going to be calling you by your first names from now, if that's okay. It just makes the discussion flow a bit better. Please don't take this as a sign that I respect your expertise any less. Of course, we all do. Now, it is important to note that Tourette's does not lead, nor does it cause mental health disorders, but it does correlate with a higher prevalence of those, and it does present unique considerations for diagnosis and treatment. And one of the reasons why we wanted to do this session is because knowing the signs of these mental health challenges that they often accompany Tourette's is key to providing parents with expertise they need to find a multidisciplinary treatment approach that's built around the unique needs of their child. So we're going to dispel some myths around Tourette's, and we're going to get into it. The format is going to be a roundtable discussion. The clinicians will answer questions, they will build on each other's answers, and we hope that this format will inspire you, the attendees, and again, thank you for joining, in asking your own questions, and you can use the Q&A feature below to do those. Dr. Benson, William, why don't we start with you? Can you help us define Tourette's and outline what we know about the relationship between that disorder and other mental health disorders?
Sure, absolutely. So Tourette's disorder, also called Tourette syndrome, is a neurological disorder, as you mentioned, that consists primarily of motor and vocal tics. So tics are involuntary movements or sounds that occur. They can be simple and quick movements and appear clearly, not purposeful, and they can range to what are called complex tics that may mimic or appear to be more like purposeful actions, but are occurring involuntarily. The person does not mean to do them. Tourette's disorder is diagnosed when a person has multiple or a history of multiple motor tics, so tics involving movements of muscles, and at least one or more vocal tics, so involuntary vocalizations, which can include sniffing or snorting, sounds, and sometimes syllables or words. And these, some some of these tics or some level of them doesn't have to be the same ones constantly being present, because they do change over time, which we can talk about a little as well. But in general, tics have been present for at least a year for the diagnosis of Tourette's disorder to occur. So as we talked about, and we can get into more, it's a neurological condition. We understand some around brain areas that seem to be involved, but it's also what's called idiopathic, which means that there isn't like a specific injury to the brain or lesion or sort of physical illness that that results in these tics. We don't fully understand completely the causal relationship, but usually starts in childhood. So that's the other thing, is that tics need to be present before age 18 usually to be diagnosed with Tourette's as well.
Now you mentioned that the behaviors must present themselves for at least a year. So what are the earliest signs of it? How early can it be diagnosed, and how is it typically diagnosed?
Absolutely. So typically the first tics are noticed often between the ages of 4 and 6, and this can range quite a bit. The average that they found is 6 years old for onset. But sometimes children can be older and even into early adolescence before tics are noticed. Usually it's a parent that notices something, and often the first tics or the first signs, as you mentioned, are facial tics. So it could be eye blinking, so rapid blinking or unusual blinking, more intense blinking than than would be typical, or some sort of facial twitch or movement with eyebrows or other facial muscles that parents often notice that this is happening more frequently. And actually, tics that last around a month or sometimes a couple of months are actually fairly common, much more common than Tourette's itself. And so sometimes parents will notice things like this that go away on their own. But in the case of Tourette's, usually what happens is these tics persist and often sort of evolve, in the sense that new tics develop, original tics that were noticed may kind of go away, but other tics develop. And sometimes in terms of motor tics, while they might start in the face, they can start with other muscles as well, but the face is most common. And then sort of as kids get older, it's more common that to see tics that are farther away from the face, that involve the arm and hands, that involve the legs or feet, and sometimes abdominal muscle that might look like twitching, and also the complex tics that I mentioned before that look more like purposeful actions, or could be multiple different tics that kind of occur in a sequence together. So like eye blinking and an arm movement and something else, but it kind of has that sequence, and you see that same sequence repeatedly. Those tend to occur later, after simple tics have been noticed. And sometimes parents are thinking that some of the simple tics might go away, or it might be the result of just like irritation or allergies or some other cause. So sometimes there's a delay in diagnosing, and parents might to take their kid to the pediatrician or to an ENT or allergy doctor or something like that first. But generally, when multiple other kind of tics are noticed and they see that there's a sequence, that's when it's more likely to be diagnosed as a tic disorder. And certainly vocal tics also tend not to be the first that develop. It tends to be motor tics that develop first, but not always. And so when there are also eye blinking and sniffing, or sometimes noises, and maybe there's arm movements, it becomes clearer, and a pediatrician may be able to diagnose, or may refer the family to a neurologist, or the family may hear and searching and kind of wondering what's going on and finding information. They may go to a neurologist or psychiatrist who can usually definitively diagnose Tourette's, as opposed to another explanation for the movements and sounds.
Got it. And can you help us sort of, last for this section, just briefly understand some of the misconceptions about Tourette's that parents should be aware of? And, you know, what are the alternative explanations that sometimes are attributed to the tics?
Sure, absolutely. So I think that's a really great question. So, there's this sort of common expression that I imagine a lot of people on the webinar have heard of, a nervous tic, right? And people sometimes think of that. And when they think of tics, this kind of tic, they think of nervous tic. And often, so they associate that with anxiety and think that tics are sort of caused by anxiety or a manifestation of anxiety, and that sort of the treatment for the tics needs to be some sort of anxiety treatment. So that's one common misconception. So it is, as we talked about, a neurological condition. We don't know all the causes, but it's not directly caused by anxiety. Now, sometimes, anxiety can be comorbid, and obviously we're going to talk about other conditions as we alluded to before. And when a person is experiencing a lot of stress, which may be a time that they're also experiencing a lot of anxiety, sometimes that might exacerbate tics. So you might see tics tend to, what we say, wax and wane, which means there are times when they're more frequent than others. Some of this change is kind of random, or we don't know exactly why it's happening more at these times than others. But sometimes times of high stress are things that will cause more, but it's not an anxiety disorder or caused by an anxiety disorder. So that's a really important distinction.
Yes.
The other misconception that people have about Tourette's is people equate Tourette's with what's called coprolalia, which is saying curse words or other, inappropriate or obscene things. And, this is often where we see the word Tourette's used in popular culture, TV shows, and things like that. And so people think that that is sort of the definition of Tourette's, or if someone has Tourette's, that they say curse words. But coprolalia happens in less than 50% of people with Tourette's. And certainly, you don't have to have that in order to be diagnosed with Tourette's. So, there's certainly other misconceptions that we could discuss or may come up, but those are probably the most common that are really important to understand.
Excellent. Eric, moving over to you. In all the literature that I've been reading about Tourette's, certainly there are multiple conditions that are co-occurring, but ADD, ADHD seems to be the first one, at least in the CDC literature, that's being mentioned. Can you help us understand the clinical definition of it? And then as a follow-up, what are the most common signs of ADHD in children with TS, and how do they differ or overlap with typical ADHD symptoms?
Sure. And these are all very important questions, because ADHD is one of the most common disorders for children and one of the most commonly co-occurring disorders in Tourette syndrome. Estimates go anywhere between around 60% to over 80% of people with Tourette's also have ADHD as a separate co-occurring disorder. So if you treat the Tourette's and don't treat the ADHD, they still have ADHD. So you will hear people say, like you mentioned, ADHD and ADD. There's only one disorder now, and that's attention deficit hyperactivity disorder. But it's characterized by two different sets of symptoms. One is a set of symptoms that are considered hyperactivity or impulsivity, and that's an overaction and overactivity. And the others are inattention. And that used to be considered maybe more along the lines of ADD, without the hyperactivity. But really, you're looking at both, and there's 9 of each. And if somebody is under the age of 17, they need to have at least 6 of those symptoms in one group to qualify for the disorder. They can have both. If they have 6 or more symptoms in the hyperactive group, they will have ADHD, primarily hyperactive in impulsive type. If they have 6 or more in inattention, they will have primarily inattentive type. And if they have 6 or more in both, they will have combined. So those are the three different kinds. The difference is if somebody gets over the age of 17 and up, they only need 5. But this is considered still a disorder of childhood. You have to have at least some of these symptoms that you can show started before the age of 12. And in general, what we see is the symptoms actually are similar in terms of the age of onset to Tourette's, where you're going to start being able to see symptoms around age 5 to 7. You can see it much younger and you can diagnose it younger, but we generally don't want to do that. Most people are diagnosed in school. So once they're sitting down and have to pay attention and restrain their behavior for long periods of time, then it's a little more evident. So, but beyond these, the most important thing that many clinicians, including myself, will look at now is not necessarily just hyperactivity and inattention, but this is a disorder where the chief feature is deficits in executive function, with executive function being the organizing principles of the brain that allow you to plan activities, that allow you to know when you have to start, to allow you to know how much time you're going to need, how much effort you're going to need, how to inhibit your behavior. These are where the deficits are. And this is what causes kids problems. Hyperactivity is the most notable. It's the most obvious. But the other stuff is harder to see and actually causes them long-term difficulty. The question of the most typical signs of ADHD in kids. We're going to look at school. So what you hear are kids who interrupt a lot, who have social difficulties because they barge in on others. That falls towards hyperactivity. Kids who don't wait to raise their hand. Kids who get up and they are moving around too much. Kids who don't seem to be paying attention. Kids who don't seem to have followed what was going on, kids who are disorganized, who've lost their assignments. What we look for many times, like let's say in our practice where we're interviewing adults to see if they had ADHD when they were kids, we ask them things like, what did your teachers say in the comments on your report cards? And they'll say, well, didn't work up to potential. It's like, okay, so they think they're not getting stuff done. Difficulty organizing themselves, talks too much, too social. We look for things like that. They may not have had behavioral problems in the traditional sense that they were getting in trouble, but what they may have by extension is that they are perceived as not getting things done, as being disorganized, and as having overall problems with planning and effort. And the last one, I know you had said, how can parents differentiate between hyperactivity and Tourette's? Was that the final? So unfortunately, I think they're very different. Sometimes they get confused because they see, you see the actions that people have. But in Tourette's, like Dr. Benson was saying, you're going to see repetitive actions, in particular in kids around the face. For kids who have hyperactivity, they're not repeated actions. They're more things that happen in a situation. They may be fidgety. They're just doing things, but those aren't repeated, and they aren't necessarily things that they will feel anxious if they stop doing. So what ends up happening more than anything when people want to differentiate it is they're thinking of one disorder. So sometimes they have trouble realizing that there's another condition. Well, how do I know if this is, it's like, well, because kids with Tourette's who have ADHD look like other kids with ADHD. The ADHD isn't particularly different for them. So you have to think like, well, all these things are not tics. Does it look like ADHD? Then it probably is, if that makes sense.
Yeah. So if I understand you correctly, and again, I'm going to translate it to layman terms. If we're looking to differentiate between ADHD and tics, we have to look at each of them and the presenting behaviors independently, and therefore, there make a decision. Understood.
Yes. One last thing, you may find that impulsivity drives some action in Tourette's, but it's not really enough to be the main thing you're worried about. You can see the things as separate actions. Understood.
Okay, we're going to continue on this theme of trying to differentiate and moving on to Lindsay. So behavioral disorders, and again, you'll help us understand ODD and what that means, but critically, help us understand how ODD, once you explain to us what that is, how it presents itself in kids with Tourette's compared to those without. And again, like Eric just did, help us understand the difference.
Sure. So ODD is oppositional defiant disorder. And what that means is a child's mental health disorder in which their behavior is oppositional. They're defying parents, they're defying rules, they're breaking standard rules across different settings and with different within different relationships. All kids act out sometimes, but this is a more pervasive and problematic behavior. A professional needs to make all of these diagnoses that we're talking about tonight. But in general, these are patterns of behavior that exist within relationships beyond just one sibling or parent relationship and persist for over 6 months. And that really is a long time. Like I have a 5-year-old and an 8-year-old right outside the door. And when they're, acting up for a period of a couple of days or weeks or even just hours and minutes, it can feel like forever. And so this is really, to think about it for 6 months, is a persistent, disruptive behavioral pattern. This can include being angry, irritable, losing temper, being easily annoyed and arguing with authority figures and refusing to follow rules, and blaming others, externalizing for their own mistakes or behavior. So again, this needs to be diagnosed by a professional. But when we think about it in relationship to Tourette syndrome, we can think about this concept of disinhibition. So this ability to really put on the brakes when we are feeling out of control or when our emotional state is heightened. So both ODD and Tourette syndrome can present as a very inconsistent ability to put on the brakes. So once one is engaged in a behavior that is disruptive, it can be harder to stop it. And it can be more difficult to sort of, when you're in the moment of being either upset or dysregulated or emotionally heightened, that system in your brain that puts on the brakes and that can adhere to sort of social norms and the expectations that your environment has for you can fail. And that can persist over like multiple sort of settings, so that the Tourette's can really kind of just, that can cause or weaken or kind of it can get in the way of that braking system across other settings as well. And that child can feel out of control. So for example, I think all of us on this webinar can imagine a situation where we are stressed, where we may have a normal like life kind of hiccup that presents. We are already stressed out and our reaction is bigger, and it's harder for us to control and regulate our emotions in that moment. And that can be the case for kiddos with Tourette's and ODD persistently. And they can be persistently kind of exhausted by this and feel badly about themselves, which just kind of perpetuates the behavior.
Right. Thank you. Taylor, over to you. Again, trying to tease out the difference this time in your area of expertise between OCD, which, as I understand, also is characterized by repetitive motion, versus tics and Tourette's. How can parents differentiate between the two?
Yeah, that's a great question. And I'll start by talking a little bit about OCD and then talking about how we might be able to differentiate those behaviors in OCD and those behaviors in tic disorders and Tourette's.
Mm-hmm.
And what we know is that, as was mentioned earlier, OCD is highly co-occurring with Tourette's. Estimates from research is somewhere between 30 and 60% of people with Tourette's or tic disorders will have a comorbid or co-occurring diagnosis of OCD, whereas OCD occurs in about 2 to 3% of the population otherwise. So you can see the large difference there.
Yeah.
OCD specifically is defined by, so OCD stands for obsessive compulsive disorder, and it's defined by obsessions and compulsions. Obsessions tend to be thoughts, images, or impulses that cause unwanted distress or anxiety or discomfort that then lead to a person carrying out usually some sort of repeated or ritualized mental or behavioral action that serves to get rid of the anxiety or the distress that was caused by that initial thought or image. And so when we think about obsessions, those tend to be things like fear of contamination, fear about germs or getting sick, fear about doing something bad or something bad happening to somebody else or to yourself. It can also be discomfort associated with feeling unsymmetrical or imbalanced or something not feeling just right. And then those fears or feelings can lead to compulsions, which can look like checking, compulsive cleaning. It can also look like evening things out or making things symmetrical, or having to do something in a certain way until it feels just right. So just by that definition, you can probably get a sense of how that might look similar to some of the motor and vocal behaviors that we see in tics, because they both have these repetitive quality to them. What we think about in tics, like William was talking about earlier, is that these are sudden involuntary motor or vocal behaviors that tend to be tied to what a lot of people call like a premonitory urge, or this sort of underlying sense of an urge or a feeling of tension in the body. And the tic happens in order to relieve that sense of discomfort or response to the urge. And so I set those two things up because I think that's also how we think about differentiating obsessions from tics. Usually if I'm trying to differentiate the two, I'm thinking about specifically what is the function of the behavior. For OCD, those compulsions are meant to alleviate the distress or anxiety or fear that comes from the obsessive thought or image that popped into a person's head. Whereas for tics, that repetitive motion or behavior is meant to relieve the physical discomfort or tension in the body. It's not necessarily related to like a fear or an anxiety or a concern about a bad thing happening if they didn't do the tic. So it tends to be those differentiation. And sometimes it's a little bit of both. So it can sometimes be really hard to tease those things apart. And that's where we get into an area that's been coined Tourettic OCD, which is a term coined by Charlie Mansueto in 2000 and colleagues in 2006 that gets at this sort of gray area that can exist between tic disorders and OCD, which can look like some of these compulsive or ritualized or repeated behaviors that look a lot like compulsions, and they tend to be driven by this sort of something not feeling right or feeling like things need to be symmetrical. But the function is to relieve this sort of internal amorphous feeling of distress. So it's not a fear about something bad happening or something bad happening to yourself or other people, but just like, if I didn't do this, I'm worried that I would just feel uncomfortable forever. This would never go away. And sometimes that can be like a little bit of an overlap between what we think of as OCD and what we think of as tics. So I guess to answer your question, it's not fully clear.
Yeah.
I always ask, what is the function to differentiate those behaviors? And then sometimes it can be a little bit of both.
Understood.
And just to kind of follow up about that kind of overlap, and I think also as Eric was mentioning about how sometimes tics can sort of seem impulsive, or they can seem like this impulsive behavior. It's not all of the symptoms of ADHD, but so we see this overlap, we see these comorbid diagnoses, and we, as I was saying before, we don't know the exact cause, right? We're still studying that in the brain. But we do think there is also a causal relationship where in that may involve similar brain areas, in particular areas like the striatum, which is involved with movements, and the prefrontal cortex, which is involved a lot of times in this inhibition. So like what Lindsay was talking about like not being able to inhibit certain actions, even though they could be very different actions, mental things, worries, thoughts, versus like particular motor movements. And so there may be that the way that these systems are these circuits are functioning in people that have Tourette's is different, and that's why there may be this relationship, because similar circuits we think are involved likely with ADHD and with OCD. So I just wanted to put that out there as well.
Wonderful. Well, we're at about the 30-minute mark. This is where we typically like to go into solutions, right? We promised people practical advice. So maybe let's start there. Until let's stay with you. The key word here is practical. So what practical strategies can parents implement at home to help their child manage the OCD compulsions and or the Tourette's tics?
Yeah, that's a great question. And I can think of a few practical strategies. I think one is something, well, let's see, to think about sort of a few different things. One is reducing accommodation. One is shifting attention. And then one is validating the emotion. So I can talk about each of those. And these probably have some overlaps with what other people are going to share as well, I would imagine. So when it comes to helping kids manage OCD and tics at home, one thing that we think about, and I think it's been talked about in other Fort Health webinars, is that actually we don't want parents to be shifting their behavior or shifting their home environment to accommodate a child's anxiety or OCD, because that can inadvertently make that behavior worse. It's one of those things where we think it's going to help if we do something that either reduces a child's anxiety in the moment or helps them avoid ever experiencing anxiety, but actually that can mean the next time it comes up, that anxiety is even bigger. And so at InStride, we work with parents to notice when they're changing their behavior to accommodate anxiety or OCD in the home, and then practice rolling back those accommodations or reducing those accommodations, which give the child a chance to experience some of that distress and discomfort and learn to tolerate it, which ultimately helps build resilience over time. So that particular recommendation is a little bit counterintuitive, because a lot of times as parents, we really want to make our child feel better in the moment. We want to do anything that we can to help bring down that anxiety, help them calm down, help them regulate. And sometimes in the moment, the best thing in the long term is actually to allow them to experience some of that distress, get some learning from that situation, that they can handle it, they can tolerate feeling uncomfortable, and then go about their day so that they can then build that resilience for the future. I can jump to the other two as well, but I can also pause there.
No, let's pause there again. Very, very, very pertinent advice. Also repeated exactly in one of our previous shows by a friend of the show, Dr. El Leibovitz from Yale Child Study Center. Let's briefly touch upon the other two.
Yeah, absolutely. So another one is shifting attention. So we think about attention as sort of the currency that you pay your child with, which means that parental attention in any way reinforces child behavior. And so whatever parents pay attention to, that behavior in your child is actually going to keep happening. And this is also really counterintuitive, because we think sometimes that negative attention is going to keep that behavior from happening, when actually it doesn't matter whether that attention is positive or negative. Any attention is going to keep that behavior in play. So this goes both for OCD compulsions and for tics as well. Our recommendation is to shift parental attention away from those behaviors, with the caveat that as long as it is safe. So if any behaviors are unsafe, obviously that's going to require parental attention and intervention in order to keep everybody safe. But if the behaviors are not unsafe, we recommend shifting attention. We think of this as, we call this watering the roses, not the weeds. So if you think about all the behaviors that your child does, there's positive behaviors, and then there's those problem behaviors. Those can sometimes look like tic behaviors. Those can look like obsessive compulsive or compulsive behaviors, and they pull for our attention. And we think of parental attention as like the water, the fertilizer, the sun in a rose garden. And we want to give that water and fertilizer to the roses, to the positive behaviors, and not give it to the weeds, to those problem behaviors.
Right.
So that can be, I think, really challenging, because it's natural for our attention to go to those big behaviors that are happening with our kids. But as much as possible, we want to focus on the strengths and shift attention to those positive behaviors.
Excellent. And for those interested in a similar technique called active ignoring, please email us. We can send you more material on that. And the last one?
So the last one is validating the child's emotion. So again, a lot of our attention goes to the behavior, and sometimes we inadvertently skip over the emotion that a child is experiencing, or the messages that we give them is, you don't need to feel afraid. You seem afraid, or you seem worried, or you seem upset, but you don't need to feel that way. Let me tell you all the reasons why you don't need to feel that way. And of course, that's meant to help our kids feel better. But unfortunately, anxiety and OCD don't listen to logic or reason. All kids hear is, you don't understand how I feel. And so what we recommend is using language like, it makes sense to me that you're feeling worried right now, or I understand that or I can see that you're feeling really scared, or that this is feeling really hard or upsetting for you. That makes a lot of sense. So just letting them know that you see how they're feeling and you understand how they're feeling, even if it doesn't fully make sense to you, that you can imagine if you were in their shoes with their fears, that it would make sense that they're feeling this way.
Excellent.
So validating that emotion and letting them know that you see how they're feeling and that it's okay to feel that way, even if we want the behavior to be a little bit different.
Wonderful. Moving on potentially from not accommodating to your child to actively trying to change behaviors. Eric, I want to move to you. What daily routines or structures can parents establish at home to help a child with both Tourette's and ADHD maintain focus and reduce that impulsivity?
This is a great segue from what Taylor was saying, because for this, it is the opposite. You are going to modify the environment. You have two basic approaches. You can try and change the person. You can try and change the environment. And like, how do you make that decision? Well, you try and change the environment if you can't change the person. So what we're looking at ADHD, you're looking at those executive function deficits. And my favorite analogy for this, and the one I use all the time, is being colorblind. So I apologize to anyone who's colorblind. This might be a harder analogy to go with, but what I usually say was something like this. Imagine that, you as a parent not being colorblind, you have a red apple and a green apple, and you're showing it to your child and say, this one's red, this one's green. I want you to go in that room and I want you to pick up all the red ones. The child says, got it. They go in the room and they pick up a bunch of different things. They bring them all back and then say, what do parents do? What did I say? I told you this is the red one and this is the green one. I want you to go do this. And they'll go in again. Or they'll say, I want you to repeat it back to me. Well, I'm supposed to pick up this one and this the other. This is the issue. They know what they're supposed to do, but executive dysfunction makes it so that they can't do it. They can't do it independently. And this is the frustration of the child with ADHD. They know what they're supposed to do, but it doesn't help them at the moment. And that's a paraphrase of something that a famous ADHD writer, Russell Barkley, said. But that's it. They understand. But where we fall short a lot of times is we keep trying to explain it to them. But that's the mechanism that doesn't work. It will never help them. So what's an obvious solution if you're looking for something red and green? It's like, take one of those and get rid of it. Just make it that there's only red ones and they can pick up that. This is the approach we want. What we need to do is take that internal executive function and externalize it so that they can follow it. It doesn't mean doing it for them, but you're taking these things and making them on the outside. If you have a system that they need to go through, or they have an order of things they need to go through, you may have to step in and say, I need you to do this part now. Give them one thing, then check that. Did they do it? Now we do this part. Did they do it? You need, or somebody needs, to be outside supervising or reducing the opportunities to do something wrong. So we're not talking about, like, for impulsivity, we don't really reduce impulsivity. We reduce the chance of being impulsive. And where you'll see this a lot of times is you're going to remove distractions for where they need to work. You're going to set up a time that you are going to have to monitor, that they are going to work from this time to this time in this area free of distractions. And what you need to be aware of is that the average person with ADHD will often think things like, I study better if I have a podcast on, or I study better with music. They don't. They just think that they do, because it gives the illusion of attention. As you move from thing to thing, you feel like you're paying attention. When you remove all those things, they'll say, well, I can't pay attention at all. Their attention is not necessarily any different. They're aware of it at this point. So this is what you need to do, is you remove these things that are actually getting in the way. You give them a steady time, a steady method to do the work or whatever else they need to do that does not change from day to day. But do not think that you can just walk away from this and they'll get it independently, which is the mistake that schools make often as well. Well, we want to teach them independence. Well, they're not going to learn it. It's not that kind of thing. What they need is they need a system to work around it. We cannot expect them to do it independently. What we're looking for is for them to do it at all. So if they need some assistance with getting it done in a particular way, of staying on track, of monitoring how much time they're spending, that part has to come from the outside, at least initially.
Okay. There was a comment or a question here. Somebody wrote here, this sounds textbook. Can we have more practical examples? Now, that happened 8 minutes ago, but I want to drill down on that, and I want to challenge, and this is an open question to you guys. The relationship between, Eric, what you just said, don't try and change the behavior of the person, change the system, create a system in which they can behave in ways that are conducive to the way we want them to behave versus, or how does that relate, Taylor, to what you said earlier, right, about active ignoring and catching the good? Help me understand the relationship between those two concepts.
Me or Taylor?
Either of you.
So
Let's
how about
start
you,
with
Taylor?
Taylor.
Yeah.
Sure, I can hop in. Yeah. So the relationship between I just want to make sure I understand the question. The relationship between changing the environment to support executive functioning challenges in ADHD and shifting attention for anxiety.
Yes. Or shifting attention for ADHD as well, right? We have changed, again, I'm a layman, right? I'm not a clinician. We have created a system or an environment where the child will behave in ways that are conducive, right, to the way we want them to behave. And now they're starting to behave like we've changed the system. How do we shift our attention, provide praise, validate? How do we essentially reinforce the positive behaviors that were triggered by the system?
Yeah, that's a great question. So, and I love the terminology that you used of active ignoring and catch someone being good. I think so often what we see is an imbalance in where parental attention is going. Which is really natural, that those challenging behaviors at home, whether they're coming from ADHD, whether they're coming from OCD, coming from tics or ODD, that is where parent attention tends to go. And so we see an imbalance in negative attention and positive attention. We want to shift that imbalance. And so I think especially when doing things like what Eric was talking about, of shifting the environment in order to set your child up for success, it's really important to then reinforce that success and reinforce them doing those small behaviors. And sometimes what that can look like is reinforcing or praising or giving positive feedback to very small steps in the right direction. So for something like ADHD, maybe it's that your child didn't finish the whole project, but they were able to read the instructions and tackle part 1A. That may feel, as a parent, like it falls short of the ultimate goal. But we want to give it lots of attention, lots of praise, because that's going to keep that behavior happening.
Excellent. Eric, anything to add?
Yes, I think one of the ways to think about it is if you are reinforcing a behavior that's driven by anxiety, when you're looking at something like OCD, you're going to reinforce the anxiety. ADHD is not driven by a mood. It's driven, or it results because of a deficit, like any other deficit, like being colorblind. They're not doing it on purpose. They cannot control it. They can't see it. So there's the difference, is by modifying the environment, you're allowing them to move past something that doesn't work for them. You're not reinforcing a behavior that is inherently the problem. You're trying to give them a different way to get around a system that isn't functioning correctly, and you can't make function correctly. You wouldn't do the same thing if someone had a visual impairment. If they can't see things, you wouldn't say, well, you're not trying hard enough or anything like that. It's like, no, they really can't see. You have to do something different. So it's the nature of the problem, and it's the nature of the solution around it, what you're trying to change.
Right. I want to now sort of expand the circle. We talked about kids, we talked about parents. I want to talk about the environment. I think Tourette's, TS, there's a lot of social misconceptions, misunderstandings. William, over to you. Can you, what advice do you have for parents dealing with those societal misunderstandings or stigmas or judgments related to tics and TS?
Yes, I mean, that can definitely be a problem, right? Because if you're a parent with a child with Tourette's or tics, you may know some of the things we've already, or many of the things we've already talked about, but you know that a lot of other people that the child encounters, peers, teachers, right, coaches, don't have this knowledge and don't understand Tourette's, because there are these misconceptions. So I think there's a couple of things. One thing is, I think that you have to be very conscious of maybe your own, kind of related to what we were talking about with ADHD and OCD and the treatments. I think with tics themselves, we think of it more as, again, it's involuntary. It's not something that can be helped. It's not driven by a thought per se. It's driven by attention. There is therapy that can help reduce tics, but it's not something that the environmental response is the key factor, right? And so it can be parents' tendencies to want to maybe try to tell the child to, not have tics, or to try to calm them down so they won't have more tics in a certain social situation, because other people might look at them or be very, kind of concerned about that piece, and could make their anxiety about those situations worse, or could exacerbate tics by drawing a lot of attention to it, sort of with the child, versus kind of ignoring and sort of giving the message that, it doesn't matter that you have your, like your personality is going to, shine through, other things are going to happen, like, sort of instilling confidence in your child, so that they can kind of ignore when these things are happening too, and still be social and kind of do what they need to do. It's also important, though, to be an educator. Like if you have a child, with tics, you want to sort of develop a little, at least elevator pitch for certain people, when you need to communicate about what tics are, that they're, involuntary movements the child can't control, but otherwise, like, they're fine. It may appear, if you see something or it appears distressing, like they're okay, the best thing to do is to ignore it, right? And for when it comes to teachers or people who are going to have more of a long, and other adults who are going to have more of a involved relationship with your child, you might want to, set up times to talk with them more and educate them about what Tourette's is and what the appropriate responses are, that in most of the time that they need to be ignoring the tics and not reacting to them. And also that, I think the other thing that sometimes people like to do is, if someone's ticking a lot, they might give them a break, like in school, like, go to the nurse, or, do you need to take a break? And even though tics are not primarily influenced by those environmental responses like anxiety, for example, sometimes secondarily it can exacerbate tics if the sort of result of having tics is like being able to sort of get out of things or take a break, or gets a lot of attention from others. So again, providing that education to other people in the kid's life that need to know can be really important as a parent.
Excellent. I want to take the concept, William, that you said about elevator pitch, and over to you, Eric. That's also a question that came up in the chat here from Angie. And let me just ask it the way she asked it. How do you explain, and let's do an elevator pitch, to teachers and family members that the child is not being, and I quote, bad or just difficult? So help us understand practical tips. How do we advocate for a child in the school?
It's something that we deal with all the time. It happens in every school. I've been a school psychologist for 32 years, and it was when I started, and it's still now, the same sort of thing. What people often don't understand, and this is one way to think of it, is that a lot of the stuff that we're talking about here is not understood by many people in the schools. They don't know, even like ADHD, which they see all the time, they don't think of it as executive dysfunction. They think of it as something, as a maturity thing, that the kids will learn to do this. So many times, although they mean well, they're not informed perhaps in the way that we would like them to be. So any sorts of resources that you can have, like NJCTS offers free in-services for school personnel about Tourette's. Like anything like that, if the school is willing to take advantage of it, that is tremendously helpful. And it's not just you trying to explain something to people who may think that they know these things and they really don't. The other thing is, you try to convey some sense of empathy. And this is something we say a lot when we have children who have behavioral difficulties, some of which can be very unpleasant, or very difficult to deal with. When, you have to say, they're not doing this to you on purpose. They are doing this because they can't help it. You just happen to be here. This isn't personal to you. And remember, you get to go home, but the kid is like this all the time. They have to be themselves. And they have to understand that they are dealing with somebody who's having a very difficult time. We get paid to do these things. They don't. So people have to understand they are dealing with kids who can't control these behaviors, who can't change things. They can't quit school when they're 8 years old. They have to go every day and do what people say. And they have to put up with this, and there's nothing they can do about it. So sometimes if you can get this across to people, how difficult it is to be someone who has these things, you can sometimes get them, to understand a little bit more. If you have if you're working with a clinician and that clinician is willing to consult with the school, that's not a bad thing either. Where again, they can take the onus off you trying to explain it to people. They can have somebody like any of us who might be involved in these things. And I know I've done quite a bit of this, to go in and try and tell them what's going on. Trying to help them understand that, you know, tics are not a disciplinary issue, even if they seem like they might be, even if they might say things that sound threatening. When it's a tic, it's a tic. They need to understand the range of things they're looking at. A kid who has ADHD, they would like to be able to do the things you're asking them to do, but they can't. And if you are not going to help them do it, they're not going to be able to do it. A common thing we often recommend things like homework books. School psychologists do this all the time. Make sure that, you know, you write down what you have in the class so that information can go home to the parent. Teacher has to check that. Someone needs to actually step in and make sure that the kid got the information before they leave, because once they do, it's gone. They have to understand that if they want these things to happen, they have to play an active role. And it isn't just putting a kid in special education or just doing these things. They're going to actually have to change some of their own behavior. And these are standard things. This is not a parent being demanding or difficult or anything. This is how these things are done. If you want the child to do it, you have to participate and make sure they're leaving with the information so someone can take it from that point. Yeah. So, and there's a lot more you can do, but I just wanted to give you a quick overview about some of the things you can do to advocate.
Absolutely. An anonymous attendee just wrote, I'm a school nurse. Communication with the school team is key. We could not agree more. I want to shift over maybe one thing, and maybe Lindsay, you can represent the group here if you can. When families consider seeking professional support for any of the co-occurring conditions that we talked about before, are there unique signs or unique considerations or unique questions that they should ask if the child also has Tourette's?
Yes, great question. So I will readily acknowledge that I am not the Tourette's expert on this panel at all, and I defer to my esteemed colleagues and peers here for their expertise. You know, we can't all be good at everything, right? And so asking questions just around how familiar you may be with Tourette syndrome, with the co-occurring disorders, or at least the symptomology that is presenting for your child is important. And a good clinician will say, you know what? This is what I am particularly skilled at, and let me connect you with folks who are particularly skilled at what sounds like what you may need. I think that in general, thinking about, okay, my child seems to be distressed by blank versus my child is not distressed by blank. It's like the first step to acting. You know, we cannot let our emotions and our anxiety as parents lead the charge here. We need to respond to what is actually going on for our child. And sometimes we kind of project more and overinterpret what's going on for our child and kind of put meaning where there doesn't need to be. And that kind of goes along with active ignoring. You know, is our child experiencing distress because of their behaviors or their difficulty controlling their behaviors? And that's when we start thinking about seeking help and asking questions around what is your experience with working with Tourette syndrome, with working with behavioral interventions for Tourette syndrome or medication for Tourette syndrome. And, you know, again, if this is not what you can offer me, can you make suggestions for how I can seek appropriate care?
Mm-hmm. Okay. Anyone else wants to build that before we try and answer some of the questions from the audience here? No? Okay. Okay. With that, look, we've been doing this for a very long time. This is probably the most number of questions that we have received. We will do our best to answer a couple, and we will maybe try and answer some asynchronously. So let's get into one that's been repeating itself. If anyone can help us understand, can Tourette be associated with muscle movement in children with autism? What is the relationship between the two, and who can help us understand it?
I'm happy to take that first stab at that one.
Yes.
So kids with autism can have Tourette's. Those certainly can be comorbid. Most kids with tics with Tourette's do not have autism, but certainly in kids with autism, Tourette's can be often comorbid. And then it looks just like Tourette's, and your treatment would be the same, but sort of considering, the child's, differential like abilities and able to form a relationship with the therapist and things like that, if you're talking about therapy. Also, kids with autism can have what are called stereotypic movements or stereotypies. So sometimes these can appear similar to tics. Like tics, they are repeated movements, or sometimes can be vocalizations as well. And sometimes, like with tics and OCD, actually, there can be this gray area where it's hard to differentiate. Is this a tic? Is this a stereotypy? But primarily, we look at the sort of what is the cause and what is the function. Stereotypies tend to be more rhythmic, and we call tics non-rhythmic. So like a common, very, very common stereotypy that not all kids with autism have, of course, there's a lot of diversity there, but is like rocking back and forth, right? Or hand flapping, right? Those tend to be rhythmic, kind of occurring in like a pattern, whereas tics tend to seem more often jerky or rhythmic. And we also think of stereotypies as being something that usually is sensory in nature, and it feels good to do it for the person. It's sort of positively reinforced because it feels good doing that movement. Whereas tics, again, we've described there's like a tension, right? And then the movement or the tic releases the tension. I think I saw a note that there was maybe a clarification. I don't know if that was around this question, but I'll pause there in case there was.
No, I think that's fine.
Let anyone else join in too.
I think that's a great answer. I want to move another question that came up again and again. Is medication, and someone astutely asked, can we talk about medication? Do they work? Eric, do you want to talk about that?
I'm happy to give a adjacent fields perspective on that. I have to say I'm not a physician, and we can't comment on what you should do with medications, but we can talk about what we commonly see and what the literature has shown and what our patients have shown. So in general, when you're dealing with these things, especially if you're talking about the three conditions we're talking about the most today, or four, some respond to medications better and more frequently than others. When you're looking at ADHD, the first line treatment is medication. However, there's some evidence that shows, although this is debated, but there's some evidence that shows that stimulant medications, which are the most typically used and typically the most effective for ADHD, can make some people's tics worse. Sometimes people think they cause tics. There's no evidence that they cause that, but if you do have a tic disorder or underlying one, it might bring it out or make it worse, at least during the time you're having it. So when you have children or adults who have ADHD and Tourette's, sometimes you have to decide, are you alleviating one problem, or are you causing another, or where's the balance in between? Now, it's less clear for other conditions. For Tourette's, there are some medical approaches that are helpful in reducing tics. And it depends on the severity of the tic, whether that's an option that you want to consider or not. OCD, the track record is not so great with medication. In general, it's the same sorts of medications you use for anxiety disorders, but they tend to be used at a much higher dosage with lower effectiveness. So unfortunately, you get all the side effects with that. So what is typically considered the gold standard of treatment for OCD is going to be one of the contemporary behavioral approaches like exposure and response prevention. You will hear people talk about therapies for ADHD. There are not really therapeutic approaches for ADHD. There are therapeutic approaches to help you deal with the things that happen because of ADHD, but not for ADHD itself, which is always something to watch out for when someone says, I do therapy for ADHD. I am often like, I'd love to see what that is, because the literature doesn't really support that. So I know that's kind of a broad approach here, is that you're looking at, some of these things, medication is going to be your first option, or one of the things you look at the most. Others, you're going to have to be a little more tempered with and say, like, some of these other things like this are a little bit more difficult. And this is why we often prefer that this is managed by a psychiatrist who can look at the entire med profile, not a general practitioner, not a pediatrician, not for all of this together. We want someone who has experience in this and is looking at the entire picture and how these medications might interact. I hope that's a fair answer.
It is a fair answer.
I gotta say again.
Yes, it is a fair answer. It may not be fair that we have 49 open questions that we will not be able to answer live, but I promise everyone that we will convene as a team here and see what we can answer asynchronously. We have emails for everyone who asked in their name, and we will do our best and perhaps do a follow-up Q&A session, because yeah, I can see that the interest is high. I want to thank everyone who joined us to the session, to listen, to ask thoughtful questions, to engage in the chat. Thank you. I want to thank all of you, the esteemed clinicians. I want to thank your organizations, NJCTS, which is the nation's first center of excellence for Tourette's. Lots of resources there. I want to thank InStride, which is a leader, and we have done multiple sessions and initiatives with them, a leader in OCD and acute anxiety, coming out of McLean Hospital in Harvard. Dr. Benson and Chalman Institute, always great to see you guys, great partners. And my esteemed colleague, Lindsay Henderson at Fort Health. We are going to continue to do sessions every month. Our next session will be focused on ADHD, so look out for an invite to there. And yeah, thank you again, everyone, and we'll see you in November.
Thank you.
Bye.
Thanks.